So, in the last lecture we were talking about panic attacks and anxiety disorders. This is going to be a longer one because they are the most common and they have the maximum variety of disorders. So, we ended at talking briefly about the drugs in the last slide. So, the drugs are the same as we talked about treating phobias. We will talk about the drugs once we finish all this. One of the most common phobia which is associated with the panic attacks. Now you understand a person is having phobia and panic attacks can be induced with it. So, anxiety can really go to that level where there is a panic attack. So, there is a marked fear or anxiety for more than 6 months in about 2 or more of the following situation: in public places, public transportation, open spaces, in enclosed spaces, standing in line. Now, the whole fear is because escape might be difficult or help may not be available. This agoraphobic situations always provoke anxiety, and out of proportion avoidance, anticipation, as we all know, is a common feature. So, again 2% of the population, females more than this, 30% of people with agoraphobia have panic attacks or disorders. Now, all these anxiety things, they predispose people to having more and more depressive and substance use, because they may be actually dependent on the drugs which decrease like benzodiazepines, or they may learn to have alcohol to control this. So, see, this is all connected, because brain is not separating that anxiety area is different and depression is different and drug abuse is different. So, from moving from phobia we go on to generalized anxiety. Whereas phobia, panic disorders, panic attacks, agoraphobia may be situation related, generalized anxiety is a presence for many days over the last 6 months, more number of days with anxiety than without anxiety, where there is the restlessness, there is a feeling of being on the edge, being easily fatigued, difficulty in concentrating, irritability, muscle tension, the sleep disturbance, continuous, and nobody can define, nobody is able to define what exactly it is. So, and this is a common thing, people are generally apprehensive, almost on the edge, not though it affects 4 to 7%, normally happens in say 30 years, female again. Now, if you look at the comorbidity, these generalized anxiety disorder people may have some other illness also, like depression or maybe a personality issue. Panic attacks improve after 6 months. Is the longer the generalized anxiety is, the difficult it is to treat. Again, as I said about medication, there are medication like buspirone, benzodiazepine, antidepressants, cognitive behavior therapy, which helps them relax, desensitize, depending on if they is cue related, and correcting the cognitive aberrations. Now, when I will just continue it, I will not break it here. One of the most significant illness which has become almost like malignant over last few years, and the incidence is also increasing, or maybe we are diagnosing it better, is called obsessive compulsive disorder. The man who could not stop washing, and the lot of people whom you know would be washing their hands again and again, or checking the doors again and again, or there are some people when who are driving, they almost have to add up the number plate and reach to a certain number, and they will keep doing it till they really figure out. This is called, this is a spectrum disorder, which is one is the commonest, called OCD, obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, excoriation disorder. Obsessive compulsive related disorder, body dysmorphic disorder is 2 to 4%. Now, these are the people who always have this feeling, and whether their mind is creating their self image, they always feel that some part of the body is wrong, something has gone wrong. their skin is not right or their nose is not all right and their ear is not all right. These are the people who keep going again and again to cosmetic surgeons, correct my nose, correct my, and even after it is corrected, it is because the whole concept is that the body image in their own head is, there is some mismatch between what it is and what their mind perceives. So, a lot of plastic surgeons will refer it to a psychiatrist to get a certificate that it is not a body dysmorphic disorder before operating, because even if they operate, they will never be satisfied. Hoarding disorder is a lot of people who, I am sure they must be the misers of old time, people who keep hoarding things, they have this tendency. Trichotillomania is rare, but these are the people who have this habit of hair plucking every time in stress. So, lot of these people have, they cover up superficially with the hair, but they have this whole area of baldness. This is called impulse discontrol. They resist, their mind is telling them to pick up the hair or just pluck it, but they resist it to a large extent, and but at a certain point of time they just cannot. So, they will pluck it, after which they feel guilty. So, this lot of this impulse discontrol also happens in gambling, in lot of people who suddenly put fire to things, and lot of anger outbursts are impulse discontrol. So, let us come to obsessive compulsive disorder. Obsessions are recurrent and persistent thoughts, impulses, images or phobias that are intrusive, unwanted, but if you try to stop them, they cause lot of distress and it creates huge anxiety. They are ego dystonic in the sense they are not in your general scheme of things. So, the most common of them are, and compulsions. So, obsessions are at a thought level, but to control this, so there are two type of compulsions. One is the yielding compulsion, another is the controlling compulsion. They are repetitive behaviors or mental acts that person feels driven to perform in response to obsession. They are aimed at reducing distress or preventing some dreaded situation. They are not connected in the, so lot of people think that okay, if I do not do it this way, if I do not keep my phone in a certain way, something will happen. This is called magical thinking, it will not going to happen, but their mind keeps telling them. Somebody, there is a obsession of dirt, that you wash your hands and your mind tells you it is not clean. So, you try to avoid it. The more you try to press it, the more the firing happens in the brain and the anxiety increases. So, either to avoid that, either you have to yield to it, to go and wash it, or to avoid washing, you start doing something else. Maybe you take a rosary and you start doing this, or you maybe you can start taking God's name. So, this is a mental compulsion. Now, external compulsion, not to avoid washing, maybe you tap 4 times. Some people, their mind tells them, okay, fine, add this car number 4682, but they have to do some mathematical operation to bring it to a number 2, but that is the compulsion. They cause marked distress, they take more than 1 hour per day and cause clinically significant depression, almost hampers the life. But believe me, this 1 hour may be a definitional thing, it causes hell lot of damage before that. Most people, they keep struggling with it to a point where their daily routine, their daily lives, everything is almost stopped. So, there is a sense of irrationality in it, but as time progresses, sometimes the rationality may be lost. Like you say, with good or fair insight, they recognize that beliefs are definitely not true. With poor insight, they think they are probably true. With absent insight, is completely convinced that compulsion and obsessions are true. 2% of general population, I do not know whether it has increased, and it starts early, almost 25% they start by age 14. So, now this is the risky part, a lot of youngsters and youth are having OCD now, and here female male are equal, but males have earlier onset. The 75% have another depression or generalized anxiety. The mood disorder is very common with obsession, and normally these days when we are treating bipolar illnesses there or paranoid schizophrenia, there is a significant comorbidity of OCD with these illnesses. They are almost forcing us to think that whether the same circuits of the brain. There is an illness called Tourette disorder, where a lot of kids who have tic disorder, tics are involuntary episodic movements of facial muscles or vocal muscles, they have OCD almost comorbid with it. As you can see, 70% have lifetime diagnosis of anxiety, 60% have mood disorder, 30% have a tic disorder, and 12% people have schizophrenia and schizoaffective disorder. Etiology, again, we know the circuit of OCD, genetics, predisposition. The chemical like dopamine in schizophrenia, which has been implicated in both ways, the deficiency of which has led to OCD and treatment of which improves OCD is serotonin. So, there is a loop of from cortex, which is a higher center, to the striatum. The striatum is basal ganglia, which is deeply tucked under the ventricle, and so this is the cortex. Here is the basal, just this is basal ganglia, striatum, and this is cortex. Substantia nigra, accumbens, so globus pallidus, external globus. So, these are all part of the basal ganglia, this area. So, this is corticostriatum thalamus, which if you remember is the relay center of the brain, where all the stimulus comes are integrated and then passed on to cortex, and cortex gives a feedback loop to thalamus. This whole circuit, normally if you are doing something and the brain is firing and asking you to do something, you do and you move on to the next loop, but this probably there is this inhibition which in this loop which is deranged. So, the information of the task fulfilled does not reach here. So, it has to keep going again and again. So, but the good thing is that the 40 to 60% people respond well. Serotonergic antidepressants, behavior therapy, antipsychotic, and when they do not respond, psychosurgery. So, what is actually happening? As I showed you the circuit previously, there is an increased activity in the right caudate in some patients with OCD, and cognitive behavior therapy reduces the resting state glucose metabolism. So, this is the, suppose we divide it. So, this is the left side, this is the right side, here is this ventricle, here is this caudate nucleus. So, there is a hyperarousal in this, and sometimes we find that on both sides if there is a calcification in basal ganglia, that can lead to OCD. So, this when we do cognitive behavior therapy, the blood flow decreases here. That means, in a hyperactive state it can lead to a certain amount of obsessive symptoms. Even pharmacotherapy reduces the right caudate nucleus may be the culprit, which is a part of basal ganglia. Probably it is sending the mismatch of a task completed to the higher center. So, it is a circuit, thalamus gets a sensation of task being attempted, the sensations go, they transmit it to cortex, the cortex gets back to the plan the movement, but somewhere along the line the brain keeps firing in the same loop, because this information of task completed is not actually getting registered. So, we will come to the drugs of OCD later on. I will try to move from OCD to the other stressors, but before that let a word about OCD, because OCD is so malignant and it is causing so much amount of disability and impairment in young people, that it needs to be handled and not ignored. The common symptoms which you will see in old people, that they are spending too much time in the washroom, washing again and again. Sometimes a lot of them are very slow, that is called obsessive slowness. Their mind gets into almost a tizzy and they get ambivalent whether they have to do certain things in this way or that way, and they are not really able to perform it. There is a need for symmetry. Some people will, if they have 4 or 5 objects on the table, they will keep arranging it in a symmetrical way. Dirt, I already told you, there is something called blasphemous obsessions. People see God's picture and statue and they start getting sexual or violent thoughts. Obsessive violent thoughts are very common. Even hypochondriacal symptoms, that means the persistent fear of being ill, which is a part of anxiety disorder, can take obsessional quality. Sometimes this obsession can almost the person can lose this sense of the irrationality and it is almost become delusional. So, this is something. So, the medication which we have, as I said, are the SSRIs, fluoxetine, paroxetine, escitalopram, the sertraline. These are 4 major drugs which are totally called SSRIs. They go in the blood, absorbed in the brain, they increase the level of serotonin and gradually slow down the obsession and the intensity of it. But having said this, no antidepressant works before, and these are the same medicines which are antidepressants also, along with other medicines like tricyclic antidepressants, imipramine, amitriptyline, tricyclic antidepressants and SSRIs. They are the mainstay of treatment of depression, of panic attacks, of phobias, of obsessive compulsive disorders, because they all work through chemicals, neurotransmitters called serotonin. Some of the antidepressants work through norepinephrine. By altering the chemical levels, the levels of these neurotransmitters, they actually change the receptor level, and with the change in receptor level, the firing is changed, and that is how these medicines work. But none of these antidepressants work before, they do not show the effect before 4 to 6 weeks. So, if you know people who are taking medicines and they are restless that the medicine is not working, they have to be advised that the medicine will take its own time to work, and each medicine which has to be taken has to be given for a very, very prolonged period, because OCD can improve very fast or it may not improve over periods of 1 or 2 years. So, medicines have to be tried and they have their levels have to be titrated against the symptom. So, the best benefit in obsessive compulsive disorder has been shown to be with cognitive behavior therapy, exposure response prevention and medication. Cognitive behavior therapy, as I have told you, you correct the cognitive aberrations. Exposure response prevention is used in some OCD patients, you see that there is a cue related onset of obsessions. So, there are other type of anxiety disorders also. One of the common words used had is post traumatic stress disorder, is exposure to the actual or threatened death, serious or sexual violence, direct experiences in war, witnessed in person, learning that the traumatic events occur to person close to them, and presence of one or more symptoms, recurrent thoughts of the event. Like we see a lot of post traumatic stress disorder patients after the earthquake. People who are prone to anxiety had it, people who did not have, there was a significant increase, and they avoid these distressing memories and thoughts. As the phobic person avoids the real situation, avoid the memories of those places. They do not want to go back. Like after earthquake, if somebody has moved on, they do not want to go back. There is an intense physiological distress at Q exposure. So, the negative alteration in cognition and mood by the traumatic events, the inability to remember an important aspect. If you ask them, they will say I have forgotten, or distorted cognitions. So, see, human mind has to survive, as I told you on multiple occasions in the past. So, the mind will create any situation to avoid distress and to avoid threat. To avoid that, the mind actually at times it can, Freud may be right here, avoid remembering, suppress the memory or consciously deny it. But some of this can be almost externalized, like irritable behavior, angry outburst, hypervigilance, accelerated startle response. So, this is a very common thing which is found in 7 to 9% of the general population, very common in the war veterans. It was actually formulated from Vietnam war veterans in United States, or it is a very common thing in people who have undergone sexual assault or sexual abuse. There is an increased risk in women and younger people. Depression, anxiety disorder, substance use, somatization, dissociative disorders. This is a group of disorders, I will just mention it. What we find that again, as I said, amygdala is hyperactive, and so amygdala is hyperactive, and the medial prefrontal cortex, which actually decreases, which does the affect modulation, which actually decreases the hyperarousal, is hypoactivated. Amygdala is firing more than usual, and medial frontal cortex, which actually suppresses, is firing less. Acute stress disorder is similar as in PTSD. So, normally if you have to ask a question, you can just screen through how, whether you have experienced a panic attacks, whether you are a worrier, anything that happened that still haunts you. Do you get thoughts stuck in your head that really bother, or you need to do things like washing, checking. Whether you are in a situation where people can observe, you will feel nervous and worry that they will judge you. That is social anxiety disorder. What is the treatment? We know that the brain is firing either repeatedly in a circuit by a misjudged completion of task in OCD, or its amygdala, which is firing more, and medial prefrontal cortex is not suppressing it. It is actually the connection between feeling, thoughts, physiology and behavior. Feeling is anxiety and stress, thought is I am never going to make that deadline, physiology is increased heart rate, muscle tension, behavior is work pace, frenzy, fidgety, and obviously the brain is firing. So, what is the general treatment? Pharmacotherapy, antidepressant I told you, SSRI, SNRI, tricyclic antidepressant, TCA, anxiolytics like benzodiazepines, which are diazepam, alprazolam, clonazepam. Antipsychotics in low dose, you remember antipsychotics from schizophrenia, mood stabilizer. Cognitive behavior therapy to correct cognitive aberrations. So, what is the cornerstone? But whether you do cognitive behavior therapy, whether you use GABA to suppress, you have to crank up the serotonin. Increasing serotonin, this is one of the robust things, like amygdala hyper response leads to fear, correcting serotonin can create anxiety disorders. Any of them can be used in an adequate dose. Start at a low dose. Now, this is very important. So, even if you are treating or you are just supporting such person as a friend, you should tell them that once you start medicine, there will be an increase in anxiety. Why? Because when you are treating, the drugs go in, they increase the serotonin level suddenly, and serotonin itself, the increase in serotonin can lead to anxiety. Like if a serotonin level goes beyond a certain threshold, like this is a normal threshold, if they cross this in any mind, the anxiety will increase. So, once you give the initial medicine, it suddenly pops up. But these are medicines which are anti-anxiety drug. If we, so serotonin is a long term medicine to treat phobia, generalized anxiety, and initial anxiety can be treated by this medicine, hydroxyzine and benzodiazepine. Propranolol is a very common drug, comes in the name of Inderal. Inderal is a very common trade name. I should not be taking trade names here, but you all know it. It is one of the best drugs which students pop up for performance anxiety. Now, again as I said, the medication has to be decided by a medical person. These are again the mood stabilizers, some of them, if you remember. Now, in children and in old people, all these medicines are to be used with very careful stance, and some of them, as I mentioned it, because these medicines decrease anxiety symptoms, there is a risk of dependence. Some of them who have a history of addiction may actually not leave it, or alcohol. or benzodiazepine, but we should tell that these are not the options of treatment. Psychotherapy. So, I will skip all this, and I will just before wrapping up this whole third week module on anxiety, I would like to stress on few points. Is that now you know. So, if you ask me to just tell you briefly about what it is all about, uh, maybe I can draw a new slide if possible. Let us see if I can induce somewhere. Okay. So, the whole of thing stands like this. So, you have psychiatry, you have organic disorders, you have psychotic, you have non-psychotic, right. You have anxiety, and you have mood disorders. Now, look at it. Psychiatric disorders can be largely put into whether they have a cause, then they are organic disorder. If they do not have a cause, then they are non-organic. Within the non-organic, if they have psychosis like hallucination, delusions, lack of insight, within which we have major schizophrenia, which is a continuous illness, disorder of thought and perception, or we have mood disorder, episodes of either mania or depression. We have non-psychotic disorder, where we have generalized anxiety disorder, social phobic disorder, panic attacks, agoraphobia, and somatization, or we have obsessive compulsive disorder, which is characterized by repeated thoughts or repeated acts, which are not in general scheme of things. People cannot stop it. The more they try to stop it, it increases. And then we have group of third disorder called personality disorder, which we will discuss later. Another thing is called dissociative disorder, which is commonly known as hysteria, is decreasing in incidence, but largely that covers more or less a bird eyes view of the whole disorders. And next week, when we talk about it, we will talk about the disorders affecting children. The other thing which I would like to do is maybe over another set of lectures for 30-40 minutes, I would wish that all of you who are interested in human behavior, and if you have some cases which you think are relevant and which can be discussed, you can post it to the forum and we can pick up some of them and discuss in a separate lecture at the end of the whole course towards the last thing. Thank you.